Hello, welcome to FISPGHAN Experts. I'm Pornthep Tanpowpong from Bangkok, Thailand. Today we have Professor Michael Manfredi from the United States with us to talk about ingestion. Good morning, Professor Manfredi.
Good morning. Happy to be here.
Okay, so I think we will start with some general questions first with regards to epidemiology. So, what are the burdens of ingestion globally nowadays?
Okay. Pediatric ingestions are a significant global health issue, particularly in young children. In the United States, for example, there are approximately 90,000 reported household cleaner ingestions annually in children 5 and under. We also know that in the United States, there are also important health disparities, with children who live in lower income areas having a 21% higher likelihood of a serious ingestion. This highlights that this is not just a clinical issue, but a public health and a socioeconomic one. Now, while the data I mentioned comes from the United States, these are likely broadly applicable, but should be interpreted in the context of regional differences in exposure, prevention, and of course, access to care. Now, globally, the burden is likely underestimated since most of the data comes from well resourced centers. We know there are clearly regional differences in exposure. For example, alkaline ingestions tend to be more common in North America and Europe, while acid ingestions are more prevalent in parts of Asia. There also have been studies from areas such as in sub-Saharan Africa, including countries like Gambia and Nigeria, which highlight that caustic ingestions contribute significantly to pediatric morbidity and mortality. Uh, I also think an important part of the burden is the prevention strategies are not standardized globally, with significant variability in packaging, regulation, and safety policies. In addition, of course, we know there's also gaps in education and awareness, both at the caregiver level as well as in our communities, which further contribute to exposures and risks. Taking all these factors together, these lead to these observed disparities in increased incidence and outcomes, which cause an overall health burden to our patients.
And as you mentioned about morbidities, like what are the top three serious injuries in terms of ingestion?
Good question. Well, I think the one that I think as pediatric gastroenterologists, we deal a lot with is the strictures, esophageal stricturing, which we see. I think that's probably one of the serious morbidities long term that we see in our patients. The narrowing of the esophagus that comes from the injury leads to feeding issues, requirement of frequent anesthetics to go up to have esophageal dilation. So I think this is a significant long term morbidity. In the immediate ingestion area, the risk of perforation, I think, is something that we need to always be mindful of. That can lead to morbidity and, of course, mortality. And then I think the risk that we don't think about that often, but we really need to, is the risk of esophageal squamous cell carcinoma and the risk of long-term cancer. I don't think we actually educate our patients enough about that risk. There's data that shows that patients have up to a 3,000-fold increased risk of developing cancer, and this presents anywhere from 10 to 40 years after their ingestion. So I think the key point here is we need to educate families that even if they're doing well, they need to have screening and surveillance, which is something that I think all of us need to do better.
Okay, let's focus on the caustic ingestion. I think these questions sometimes comes up. On the other hand, like if like so many children would have in caustic ingestion, many children would have like grade 0 or grade 1 Zargar when we do the endoscopy, especially in asymptomatic children, and they don't have like significant change in terms of the management. So are there any settings in terms of like especially in asymptomatic children that we may omitting the endoscopy, especially in resource limited settings?
Yeah, this is a very debatable area. I think it's a very controversial area that still needs a lot of discussion. I think most people agree that if a patient has symptoms, we would need to investigate into a scope. There are some guidelines, especially out of Europe, that say asymptomatic patients who have a reliable history as well as potential follow-up may not require endoscopy, and you can observe them, conservatively without endoscopy. And this largely comes from one study done in a prospective study out of Italy that showed that all asymptomatic patients had no evidence of any significant injury, which they defined as a Zagar grade 2B or higher. Um, However, I do think which I think it was a great study. And again, I think the part of it is this something that can be is this a regional thing out of Europe or Italy, or is this something that could be globally represented throughout the world? So, because I do think there are other studies that came out that show that asymptomatic patients, up to 20% of them, can have findings of Zagar 2B or higher and present asymptomatically. So, I think it is a very debatable topic. So, to me, I think the factor of how injury happens is just as important. Remember, I think injury depends on several factors, right? It's the substance that you ingest, the pH, the concentration, the viscosity. Those things matter. The quantity ingested, as well as the contact time. So, I think a risk stratified approach is important. So, for example, if you have a patient that is asymptomatic and swallows a minimally caustic agent, for example, that it's not highly caustic and they're asymptomatic, I think you can treat them conservatively and not have follow up with them. In my opinion, that would something that I would do in my practice.
Mhm.
However, if I don't have a reliable history, or if the agent ingested was highly caustic, I think I think to me personally, I'm going to try to do an endoscopy, but I definitely understand especially in areas that are not do not have a lot of resources. I think you can certainly manage these patients conservatively, but I do think it's a very debatable area. And again, I have obviously. I'm fortunate to practice an area where we have a lot of resources, so definitely will scope these patients. But I agree, based on some of the data out there, asymptomatic patients can be monitored conservatively. But again, I think it is something. I think you have to keep in mind what the agent ingested was.
Mhm. But I'm sure like that all pediatricians or pediatric gastroenterologists would not want this to happen. So what would be your top three preventive strategies on the ingestion?
So again, I think I think the main things in prevention strategies, I think, are going to be continued standardized, child-resistant packaging, safer product designs. I think I think we need to, pediatricians and also need to kind of educate families about these issues in terms of what to look out for in terms of ingestions, making sure you don't have all ingestion should be in safety proof bottles and should be stored high. I do think governments need to have higher regulations, and this is something that I think we as pediatricians and pediatric GI doctors, we need to kind of talk to our governments, lobby more for these prevention strategies, because we know these things, if accidents happen, and again, if these things are preventable, I think these are all preventable issues in children that we need to kind of advocate for them. So those are the main prevention strategies: education, higher regulations, as well as pushing for better child resistant packaging.
Mhm. Thank you so much, Professor Manfredi. I hope that we'll have more time to discuss on this important topic on ingestions. So for more information, please refer to the following societal paper given within this video clip. And please stay tuned for the next FISPGHAN Expert Insights. Goodbye for now.